It has been reported that up to 20% of people will experience an episode of Major Depressive Disorder, or MDD, at some point in their lives. Treatment using antidepressant drugs can take several weeks to take effect and can be associated with side effects including weight gain, sexual dysfunction, and patient discontinuation due to side effects. Transcranial magnetic stimulation, or TMS, avoids pharmacological drawbacks but presents its own challenges relating to high cost, portability, and availability. Due to these factors, treatments with faster response rates, fewer side effects, and greater availability present transcranial direct current stimulation, or tDCS, as a potential alternative to current methods. Depression represents a disorder caused by a variety of biopsychosocial factors. These include internalizing factors such as genetics, personal history of depression, as well as adverse experiences. Depression is also associated with altered neural structure and functioning. The dysfunctional neuromodulation involved in MDD involves several cortical and subcortical areas, particularly the amygdala, hippocampus, dorsolateral, and ventromedial areas of the prefrontal cortex. These areas are associated with the classic symptoms of psychomotor changes, anhedonia, and executive dysfunction involved in MDD. Additionally, it has been shown that patients with MDD have asymmetric hemispheric imbalance related to negative emotional expression. tDCS can modulate cortical activity through hyperpolarizing or depolarizing of neurons. Anodal stimulation is commonly associated with increased cortical excitability, whilst cathodal stimulation decreases excitability. Studies have shown that in addition to changing cortical excitability, tDCS can produce enduring changes in neural activity with low rates of reported side effects. tDCS is thought to have an antidepressant effect on the neuronal networks that govern mood, particularly the left dorsolateral prefrontal cortex, an area frequently targeted during therapy. This dorsolateral region is commonly targeted due to its significantly reduced function in patients with major depressive disorder. Decreased functioning in this area is associated with low mood and anhedonia. Several studies have explored the effects of tDCS on the physiological mechanisms of MDD. A randomized clinical trial conducted to test the efficacy of tDCS for treating MDD revealed that a significantly greater reduction of depression was found in those who had tDCS of the left dorsolateral prefrontal cortex when compared to participants who received sham tDCS or tDCS of the occipital cortex. This effect persisted for 1 month after the end of treatment. In a separate single-center trial, it was found that tDCS was superior to placebo and non-inferior to the pharmacological management of depression using escitalopram. However, during the 10-week study period, it was found that tDCS was associated with more adverse side effects such as skin redness, tinnitus, and nervousness when compared to the other groups. In addition to the physiological barriers of tDCS, practical barriers exist. Electrode placement has the potential to alter efficacy and therefore be ineffective for treating depression or having unwanted side effects due to stimulation of other cortical areas. In order to ascertain the value of tDCS, studies have compared its efficacy versus pharmacological management. In a comparative study exploring the long-lasting antidepressant effects of tDCS against fluoxetine, prefrontal tDCS significantly reduced symptoms with effects persisting up to 30 days after the last stimulation session. Whilst both fluoxetine and tDCS reduced depressive symptoms, the effects of tDCS were immediately maximal, whereas fluoxetine took 6 weeks to reach maximum therapeutic effect. It could be argued that this immediate benefit may be advantageous to patients with severe depression not responding to pharmacotherapy, particularly if the disorder has a component of suicidality. In order to assess for observable physiological effects, resting state brain activity using fMRI was measured before and after receiving real or sham tDCS. It was found that significant changes in neural excitability occurred close to the primary stimulation site and surrounding regions. The study showed that real tDCS had a modulatory effect on stimulated regions and thereby demonstrating that tDCS can have a measurable effect on regions associated with MDD. Although TMS has been more widely investigated, it has drawbacks relating to high cost, portability, and availability. In comparison, tDCS is relatively affordable, small, user-friendly, and portable. Current studies have indicated it can provide immediate lasting effects in treating depression whilst avoiding many pharmacological side effects. Given these benefits, tDCS will benefit from further clinical evidence in order for its application to be integrated into the mainstream treatment of depression. Further specific directions can include analysing the long-term benefit and efficacy of tDCS, investigating the total dosing of electrical stimulation required, and applying this to individual patients for maximum benefit with minimum side effects. Additionally, future studies would benefit from larger sample sizes to increase generalizability of findings to the wider population. Based on current research, It is evident that tDCS can offer a range of benefits in the treatment of major depressive disorder. However, further investigation is required to determine optimal treatment plans and to establish its application in augmenting existing methods.